want you to do is share some of your lessons learned. Now, just kind of for background, and there's been a lot of people who have contributed here, a lot of my friends who have been in the Army with me, other people from the VA. We mentioned Susan Hamilton before, Ferris Tuma, Dan Dodgen, etc., etc. A note about the pictures. You're going to be getting a handout. The handouts doesn't have the pictures in them, but because they don't reproduce that well on a handout, so I was putting some in today. I couldn't get onto the web, so there's not very many Japan tsunami pictures. Most of them are from my combat files. So the top picture there is, and the laser pointer doesn't work on here. The top picture is after the Pentagon was rebuilt, and the bottom picture is Colonel Benedict and I in Abu Ghraib. So, as I said yesterday, and I'm going to repeat myself a little tiny bit because this is being videotaped and goes on the web, so there will be some people who won't have been here yesterday who will review it, is we've had an awful lot of combat disasters, stressors, pandemic, flu, Gulf oil spill, and we've learned a lot from all of them. And I'm going to focus on the disasters or wars that I've been part of, more disaster than war today. But again, there are many, many people who have been part of this effort. One of the things I'd really like to do is work either with this organization or another to try to have some more publications about exactly this subject. What have we learned and how can we incorporate that into planning? To remind you, and I think you all know this, every event is different. We heard that this morning, but also every event has its similarities. Natural, man-made, terrorist event, complex humanitarian emergency, and that usually refers to a combination of war, displacement, refugees, war, or what used to be called CBRNE, chemical, biological, nuclear, and then there's obviously combinations of all of the above like we see in Japan at this time. A little bit of background. Prior to 9/11, we were looking at the issues about psychological debriefings. And I mentioned this yesterday, but again, this is going out to the world over the web. So the question is whether they were doing more harm than good. And you remember that that was a big controversy back in 2000, 2001. And we were worried about vicarious re-traumatization. We had a conference which we had been planning for a year and was held in October 2001 and was published a year later on Mass Violence and Early Intervention. And that book is still available on the web. Just Google it, it'll come right down. And it was really about best practices in intervention. So again, what I want to do now is what have we learned so that it's best practices in planning. We had some discussion the other day about whether the aircraft carrier had turned around or not. If you look at the CDC website, it's got on it much of what we've recommended as best practices. But when I was talking to Steve about this the other day, you're saying that still a lot of local places are still doing critical incident stress debriefings. Now, don't get me wrong, I actually think CISD does have a place. But the big take-home message from this talk is I think you've got to do an assessment first, and then you decide after your assessment what you're going to do rather than rush in with your critical incident stress debriefings and sit everybody down before you knew what's going on. That's a recipe for disasters. So why do you do an assessment? Basically, to not do stupid stuff. Official reason, develop a strategic plan, reports to your command, either military command or your other commanders, to inform the families, the media, to figure about where your resources go and to target your interventions. Again, to find out what's going on at the crash site, but also find out what's going on in the surrounding community. And this should be an assessment on several different levels, individual, group, and population. Considering your vulnerable populations. As you all know, I retired from the military 6 months ago, and now I work for Washington, D.C. for the chronically mentally ill, with the chronically mentally ill. So I've become very attuned to the question about what happens when somebody goes off of medications. And in Washington, D.C. and many other underserved areas, metropolitan areas, what happens is people go off medications and they become assaultive and they get brought in by the police in the emergency room and they get hospitalized. Well, that assumes that we have enough medications and we have enough police, and still that happens all the time. What if you don't have a supply of medications, as we saw in Katrina with the disaster? What happens if we don't have police because they are busy in other places? So again, consider your vulnerable populations, and of course that includes the physically ill and the disabled. The basics of assessment really are looking at physical needs. And Susan Hamilton and I did publish an article on this about 2004, and we really tried to say what it is that you need to do. Now, you as mental health professionals may not do the physical assessment, but somebody's got to do it, probably Department of Health, and you need to know, because all of these things are going to affect the mental health assessment. The numbers of affected, is there shelter available? Is the shelter safe? Is there food available? Wounds and illnesses, infectious disease, medications. In many parts of the world, fuel for either heat or cooking. Fuel can be an immense issue. And then continued violence. Our model used to be there was one bomb, Oklahoma City, and then afterwards it was pretty safe. You could move as you wanted to move. You didn't have to worry about the first bomb and then all the first responders coming in and then the second bomb, or the continual violence that we see in so many parts of the world right now. So that's important from a number of points of view. One is the safety of your own workers and making sure that they don't necessarily just rush in, which is their instinct, but that they are cautious and look around and do the right thing still, but take care of themselves. And then another area which we tend to ignore is mass fatalities. Again, after the first few days, 48 to 72 hours, it's usually about mental health and it's about the bodies. And what do you do? And in our culture, it's very important for us to manage the bodies well and appropriately. And if bodies pile up, if they are lying on the beaches, rotting, as we had after the first tsunami, or in Haiti more recently, that is immensely difficult for folks to deal with. So again, in terms of specifically the mental health needs, looking at your vulnerable populations, where I live, Washington, D.C., and New York City, and many other big cities, there's people who have been in conflict areas before, many from the Middle East. There's people who have been tortured before, previous bereavement. What is your medication supply? One of my, what I call my pet rocks, an issue that I've been pounding my head against for 10 years without success so far, but I can still do it, is that the CDC stockpile for medications doesn't have psychiatric medications in it. And we've been trying to engage them, we being the American Psychiatric Association and others, we've been trying to engage them in terms of putting medication in the stockpiles. We haven't gotten it yet. And then what is hospital bed situations? Again, both general hospital and some of your folks are going to need to be hospitalized. The standard line has really been focusing on the general healthy population, but the general healthy population is probably going to do just fine, at least in the acute phase of the disaster. But some of your people are going to become psychotic and are going to need hospital beds. And then the dead bodies issues, which I really believe are psychological toxins. And if there's a lot lying around, if there's a lot lying and rotting and decomposing in the streets, especially if they're kids, that's going to be a real problem. Let me pause for a second and ask a question. Does everybody have a handout? Does anybody need a handout who doesn't have one? Okay, Lindsay here is my helper, and I'm trying to keep her busy. She's going to be running around with a mic later. And so just raise your hand and she'll bring you one. Okay, so how do you assess mental health needs? One common theme that we see in Katrina, et cetera, is the power goes out. So you don't want to get there and then start trying to log onto your computer to get information. You want to try to get as much information as you can before you get there. And it can be general information. You know, how big is New Orleans? What is the history of Baghdad? What is the history of Somalia? Whatever else, you want to try to get that information. However, that's only part of the story, and you want to get an on-the-ground assessment. I say to avoid the windshield survey. That's the driving of the Jeep and getting all your information through the windshield. That may well be part of what you do, but ideally you're going to talk to stakeholders in the community, whether it's schools, hospitals, or clergy. You're all experienced disaster workers, you know that everybody has their own interests. Everybody wants to get the funding stream to go to them, and because they're worried about their constituents, so you've got to balance all that. One of the things that has struck me in some of the work that I've done in Iraq, where we went over to help the medical system rebuild, is the depth of the divisions between different people. And so although, as you heard earlier, after a disaster there may be the honeymoon, then after that there's a bitterness. There's going to be divisions between different people. The other thing that we struggle with is we all want to get good data on the ground, but people don't like having clipboards shoved in their face. So if one can develop an easy instrument that you can do to gather data, it's good. I think it's also potentially very problematic, and it may be better to discreetly take notes and then transcribe information later. Then what are your mental health resources? Obviously personnel, crisis counseling center, clinics, medications. What about language and culture? That is always a major issue. In most of our cities, we have 80, 90 different languages, different cultures. You're probably not going to be able to have an interpreter for each. But again, if you do your homework before you go in, that may be helpful in terms of what you're likely to see. Now, I've used the term before you go in. That kind of implies the model of the SAMHSA teams, etc., Red Cross rushing in. There's also the model of you being there yourself. You are there when it happens, and you may not want the teams from outside coming in on your territory and your turf. Most disasters, there's going to be a combination of both of those, and that's something that you've got to negotiate and understand is the assessment from both outside and in. And then the assessment has to be ongoing. As you know, you've got the honeymoon period, but then you have the problems that surface afterwards. And just about every disaster we see this. Feelings of bitterness, somehow the government let you down. I think this is critically important for the preparation of the Red Cross workers or other workers, because they come in and they're not really sure why folks are angry at them. They're here to help. I mean, I left my home and my family and I'm coming down here. Why are you mad at me? Well, because you're there and you represent the government. And then the cleanup period, which is still going to be dangerous and often environmentally dirty. International issues are a little beyond, well, they're not beyond the scope of this conference. It's international mental health. But they are a complex issue, and I'll only lightly cover them. Let me ask you all, because I do want to get your input. How many of you have been involved in movements of large numbers of people, such as refugees? Anybody here in the audience? Okay. Well, if it does happen, and it may very well, if you go to the web and you look on www.sphere.org, there's a lot there that covers what your physical needs are. How much water everybody needs to drink, how much shelter, how many feet, the number of latrines, etc. Almost nothing on mental health needs. And I think, again, coming to the planning and preparation, that thinking about the resilience and how to enhance the community of a refugee camp is critically important. What's far more important than counselors is a soccer field, is a church, is latrines that are close enough and well lit enough that women and children don't get raped on the way to the latrine. And then I'm always an advocate to think about putting a garden into the refugee center. Because, of course, the refugee center is supposed to be there for 2 weeks, 6 months. And what happens, it's there for 10 years. And so anything that you can do to help establish a sense of community, a sense of purpose, and knowing that people may have a lot of time on their hands is helpful. Not much information out there yet. CBRNE, chemical, biological, radiological, nuclear agent. You know, it's interesting how it fluctuates. Around 9/11, we had the anthrax scares. We had a lot of fear. The last few years, things nobody talks about it anymore, and now nuclear is a big one. So when you're doing an assessment for chemical and biological agents, it'll be a similar assessment to what you had before. Numbers of exposed, potentially exposed. Infectivity is a big issue. Are my kids going to catch SARS from me? If somebody comes in on an airplane, is the airplane all going to be infected? Think about numbers presenting for care. And there's kind of a myth, to me, a myth out there that the emergency rooms are going to be overwhelmed with, quote, the worried well. I don't like that term, worried well. I think that in many cases people aren't going to come to the emergency room. How will you manage quarantine, if you will manage quarantine? I personally don't think we will be able to in the United States. There are still some planners that talk about it. I think snow days is a better model. And then some people call these weapons of mass destruction. We think of them as weapons of mass disruption. Usually with chem bio, relatively few people are killed. What you have, though, is major effects on the economy, like you had with SARS, where entire industries shut down, specifically around tourism and airline industry, and the economic fallout from that. Some of the things to think about that people don't know if they've been exposed. And I don't like the term worried well. The implication is people are sort of, they're feeling like, oh no, I'm anxious, I'm neurotic, I might have been exposed. Well, if you don't know if you've been exposed to anthrax or smallpox or sarin, you're right to be worried, and you're not particularly well, and there's probably going to be a period of time before you know. So a lot of anxiety and uncertainty. And then this is a smallpox case, which fortunately we don't have anymore. But if it were to come again, the question about the grotesqueness and how people would react. Wanted to spend a few minutes on disaster behaviors, and after I do that, I'm going to sort of pause for a second and get some comments and thoughts from you all, because again, this is a workshop and I want to get your thoughts. So how do we promote optimal disaster behaviors? Again, we've learned a lot. What we find is that people in general don't panic. When does panic happen? Panic happens in the crowded nightclub with one door when the fire goes out. But if there's many exits, if there's many ways to get out, people will go out orderly. Unfortunately, sometimes it takes them too long. And that we saw in 9/11, and certainly we've seen in other settings, where people don't respond as they should by getting out of the building quickly. I think that's changed a little bit. Again, now, at least for me, if there's a fire alarm, I don't just close the door and sit inside. I take it more seriously. Another issue, which I alluded to yesterday, and I think is worth coming back and fleshing out, is if the disaster happens, do you go home and take care of your family, or do you go to work, knowing that when you go to work you will be there for 3 days? And somebody alluded yesterday to, well, everybody needs to have a good child care plan. That's part of what we do. Well, I think that's actually very hard, because in disaster settings, most likely the school's going to close. You might have somebody who's supposed to come over and get the kids, but will they be able to get there? And I think we need to have a lot more attention paid as a corporation, as a country, to thinking through this in an organized fashion for first responders and anybody else. And then the question about social disarray. Again, what you often see is if there's only a few lifeboats, people rush for them, or only a limited supply of gas masks or ciprofloxacin or whatever. But if there is a feeling that everybody's going to get the same care or treatment, then people are a lot more calm, a lot less likely to have looting and social divisions. And then you also need to plan for sensory overload. In many of these settings, you're in the midst of a bomb, you're in the midst of the war. Unless you're used to it, people get overloaded, and they may or may not be able to function. Okay, as promised for a moment, I'm hoping that somebody will have a comment or a question, and Lindsay is there with a microphone. We got one there and one there. and one there. So we'll go black shirt, purple shirt, red shirt. And of course, you're going to give me your name. So after this, I can introduce, I'll call you by your name, maybe.
Okay. Martha Kenton. I'm from New York City Office of Emergency Management. And on the question of social disarray, how do you fit in this idea into self-preparedness and that sort of messaging that we would want to encourage the public to have? Because I'm thinking antibiotics and vaccines, making sure there are enough gas masks, there aren't necessarily enough for that, but the self-preparedness piece to it.
Right. I think that's a very good question. And as you know, I come from the military mindset where we are given vaccines. We're not necessarily given antibiotics. I just, as a physician, just saved my doxycycline from when it was prescribed to me, even though it's expired a long time ago. Oh, this is being videotaped. Strike that last message. I do think that from a policy point of view, it would be good, as I believe they have in Israel. Do we have our Israeli psychologists here? My understanding is in Israel, everybody gets a gas mask. And I think we probably ought to think about that as something to make things more available. The vaccine question is mainly around anthrax, and that's touchy. In the military, there was mandatory vaccinations. I wouldn't go for the mandatory vaccination for the civilian, but I think if it was offered to them and people knew that they could get it, again, that would be a lot more, there would be less anxiety around that. Ma'am, let me go to you.
Hi. My name is Lynette. I'm from Thompson Hospital in Canandaigua, New York. We're a fairly small hospital with 103 beds, but we do also have a long-term care facility attached. We used to have a daycare center for our providers that they were able to use that, but we did discontinue that. So after that, a couple of years later, we took a survey of the staff and asked them how many of them would be willing to come to work if there was a disaster, how many of them would have child care issues, pet issues, and those types of things. We have about 1,400 employees, so we took their information to heart. And so what we did as an alternative...
And wait, what did the survey say? You say you did a survey.
They were not going to come to work if they did not have child care.
Okay.
So we're improvising by taking our largest conference room, and we have a cabinet supplied with children's supplies, extra, diapers, play toys, games, and then we also have our long-term care. They have quite an extensive recreation department that has quite a few supplies too that would keep children busy. So we've even drilled before, like a snowstorm. At one time we were expecting a very large snowstorm, so we set up the child care situation for employees, and we did end up with about 14 children there for the day, and it worked out quite nicely. Over an extended period of time, we do have extra mattresses and beds and those types of things that we could bring into that room, but we would outgrow that room if it did become a long-term issue, a long-term event. So that's how we've compromised.
Well, I think that's a very good start. And why don't you go ahead and bring the microphone over to the lady in red while I respond, and then we got one down here. You brought up another point, though, too, which I hadn't really focused on, is what about if you're taking care of aging parents and, of course, pets? And that's going to be a lot more complicated, obviously, than putting some play stools up. So, and I don't think we've wrestled with that very well either.
Going back to the assessment idea, I was wondering what you thought about behavioral health surveillance methods. I don't know if you've heard of SciStart or the triage tools where they look at exposure-based risk factors. How many people, have people seen dead bodies, or were they concerned about their own safety, or is their home not livable? They have various risk factors that are exposure-based. Have you looked at that at all in terms of assessment?
That's a good question. I'm somewhat I think I've received briefings on those like sort of 6 or 7 years ago. Wait, before you take the mic away, I've got a question back for you. Are those based on individual surveys, or are they based on, I have a feeling they're based on general population, but I don't quite know how it works.
It can be a general population needs assessment type of behavioral surveillance, and they're being used in the LA County Public Health System. Chip Schreiber out of LA County Public Health Service is the one who's kind of championing it. And Red Cross is also using them as well. And they're not, you don't walk around with a clipboard and check it off, but as you're working a shelter or working a service center or wherever you are, you're paying attention to how many of these people were, lost their homes, or their homes are unlivable. Did people lose a loved one or a pet or something like that, and then keeping track of those. And we're using it in order to think about where we're deploying our mental health assets, since we never have enough. So if we've got an area with 5 shelters in it, we're going to deploy them where they're the most risk factors.
That sounds like a very good idea. Again, I've heard of it. What I don't know is how well it actually works in practice. And so I think we want to pilot test it, or it's already being pilot tested, and see how it works. Go ahead.
One quick follow-up, sorry. We did pilot test it last year in Tennessee and Arkansas, I think it was, or at least Tennessee, where there was some serious flooding last year, but we haven't had the good disasters to test it on recently. So, but we are piloting it and trying to improve it.
Okay, and for the audience, spell out or say again the names and where people can find it.
It's the tool is called SciStart, so it's PSY Start, START, and the developer is Chip Schreiber, SCHREIBER.
And is it on a website somewhere?
I don't know for sure.
Okay.
I don't know for sure. You could, if you can't find it, you can contact me and I can put you in touch with it.
Okay, and again, guys, this is being videotaped, so for the video, give them your contact information.
Okay. I'm Valerie Cole, National Headquarters, American Red Cross, and my email is Cole, COLE, V as in Victor, A, at usa.redcross.org.
Okay, great, thanks. And let me ask the people who are videotaping, are you able to swing the camera around to catch who's ever talking? No, okay. All right, so you don't get your fame and glory. Okay, up down here in front. And if you stand up, sir, you'll be right in front of the camera so you can get your fame and glory.
However, this is not going to be a whole 15 minutes of fame, just a few seconds, all right. I'm Jules Heyman. I'm in private practice in New York City.
Okay, why don't you go ahead and face the audience?
Why don't I turn my back on you? Okay, I'm in private practice in New York City. I'm also faculty at Touro College, and I can't help but think out loud about my memories back during World War II, where we had, of course, the air raid wardens. And then during the Cold War, when we would practice going to shelters and things of that sort. And I'm looking around now at the fact that we know that they're going to find some way to attack us and to reinstitute our fears and whatever has happened, to remind us again of the World Trade Center. And I just wondered, what are we doing to have on local levels and on larger levels for people to be prepared? I wouldn't know what to do in an emergency. Oh, they tell you have an emergency kit. But that's just words. How can we actually institute genuine preparedness on every level, so if, God forbid, there is an institute of what happens again, that we're prepared?
Again, my military bias is showing. You drill, drill, drill. You have exercises and you involve the population. How many people here are actively doing exercises and drilling? So maybe 25, 40% of you, maybe 50%. So I think the more you can do that, and there's always a balance because you don't want to scare folks to death, but you also want to have happen. So for example, in the metro in Washington, D.C., they've been doing some exercises where people practice evacuations, and the more of that you can do, the better. Okay, so let me come back to my talk then. And it's all about shaping these disaster behaviors so that you can promote organized, timely evacuation rather than panic. Let me run through a little bit of the acute psychiatric issues, and I'm going to do this fairly quickly because you all know it. So acute psychiatric issues that you've got the stress, you've got the fear of the unknown, the have I been exposed. One thing that doesn't get stressed enough is that you may have changes in mental status due to a chemical or biological agent. So if somebody's presenting with anxiety, well, it may be that they're anxious, or it may be exposure to sarin, or if they're talking funny and seem kind of crazy, it might be that psychosis, or it might be an infectious disease and a delirium. And one of the things we always have to be thinking about is medical triage. And let me do a side plug for a minute. All of you are in disaster mental health some way or another, I believe, or most of you. Make sure you keep up your medical skills as much as possible, whatever discipline you're in. Because if you're there as a first responder, you may well be doing some medical work. Now, some of you have more medical training than others, but anything that you can do to either keep up your CPR or become an EMT, the better. Okay, and then the question about medical triage. Are you going to try to promote people coming to the emergency room? You know, again, there's the feeling of fear that there will be 5,000 folks at the ER. That actually rarely happens. Questions about quarantine. Are people going to stay in one space that the government tells them to? I don't think so. I think that the model that we've seen on snow days now, more and more, or the model that the Canadians used during SARS, staying at home is a much more reasonable model. Somebody mentioned the question of self-care and taking care of yourself, and there's always a bottled water and the duct tape. Well, the other question is, how many people here have teenagers? Just a couple, how would you keep your teenagers at home for 10 days? Well, I hope you have a good supply of whatever that would keep them happy. I'm about to be facetious here for a minute. I think what we need to do is we need to develop a system where we have Clydesdale horses pulling wagons, and the wagons should have beer, whiskey, tobacco, and methadone. Because people who are addicted are not going to stay at home. And any plan that assumes that they will is not going to work. Now, I warned you that I was being somewhat facetious, but I think we have to factor it in and consider a Meals on Wheels model that has more than just food on it, because people won't stay at home. Then there's the other issues of loss, grief, denial, fatalism, the chronic issues, depression, PTSD, concerns about being physically exposed, physical symptoms, people who will hoard, whether it's hoarding protective equipment or anthrax, the anger at the government. What we see, again, after every environmentally dirty event is multiple unexplained physical symptoms, which has various acronyms, MUPS being one of them, economic fallout, and then with the economic fallout, the unemployment that goes with it, especially at the bottom levels of the socioeconomic ladder, people who work in hotels, restaurants, airline employees, or those who are dependent on them. Again, we've seen enough now from SARS, from other events, from what's happening in Japan right now, to what's happening in Egypt right now, where the tourism industry is out, that we need to be planning on the economic fallout of the event and how are we going to consider that. Okay, I'm going to go now to the conference that we had in October of 2001. And at that point, we developed, based on a lot of lessons learned, evidence-based principles of early intervention. Now, this should be well known to you all, but I need to have it as a platform before we move into future lessons learned. And it may be a good rehearsal. So we had 60 subject matter experts get together, and we said, what should be done? Again, in the context of, at that time, it was critical incident stress debriefings that were what many mental health professionals were using, and a lot of paraprofessionals and a lot of chaplains, et cetera, et cetera. And what we came up with, and again, I think that this has been institutionalized right now, most places, but not everywhere, is you've got to focus on the basic needs here. Communication is so important. Knowing that your family is safe. Security and survival. And until people know that, they don't want to talk to anybody for mental health, and they will resist you being there. Then psychological first aid. And that also now is well known, protecting from further harm, reducing physiological arousal. You'll see a couple of dog photos in here. I've been doing a lot of work recently with the use of canines as either with wounded service members or with service members with post-traumatic stress disorder. And I think that's an avenue we need to explore further that we haven't yet. But that's kind of another talk. Oh, I've got something exciting. Okay, we'll come back to that then. And as a matter of fact, I'm going to bookmark you, so when I go to my next round of people talking, you can talk about it. So monitoring the recovery environment, again, this is something we've known, but we continue to not do very well. Not necessarily our job as mental health people to see what the water quality is or what the air quality is, but if somebody's not doing it, we know that people are going to worry about their health. They may worry about their health even if you do it, but at least you have some data. So what is our job is to monitor the services being offered by mental health folks who want to come in and offer services. Now, I say that's our job. At the Pentagon, it was pretty easy because we had a perimeter. We could do that. We could say, you want to volunteer, you come in, we're going to look at your credentials, we're going to find what you want. But in New York City, you couldn't. Let me again ask the group here, what has been your all experience with being able to monitor the mental health services that are coming into your affected region? Is that something that's been easy to do, hard to do? Lindsay, you should be ready with a microphone. Anybody have any experience on that one? We got a lady up here in the back in the light brown shirt. And is Carla in the room? Okay, why don't you help with the other mic? I don't like this dead space so that I then have to keep talking while I've got Lindsay on the run. And I think the lady in the purple shirt had a comment there too. So we'll go to you next. Yes, ma'am.
If you have a mental health organization that is already in place and working with emergency management that's managing the incident, then they're going to be able to control who ends up doing the work. And when spontaneous other resources show up, you will have the chance to assess them if you want to use them. But again, it's that doing the proactive work and working with emergency management that's going to be managing the rest of the incident.
Okay. Ma'am. Button on the side.
Again, like I said, we have a small hospital, and we have the capability of locking down all the doors. And we have one entrance that's designated for people to come to, and they're not allowed in unless they have an ID badge that's been previously issued by our facility.
Okay. Anybody else? The other important thing is to work with who's ever doing intelligence, and in the Army we had, the intel guys, but for you it's probably police, fire, and see what other threats are going on, because many of these episodes now, sniper, anthrax, etc., they're not single threats, and there's going to be anxiety about more happening, and there often are. So monitoring the recovery environment includes monitoring for threats. Then we have a very major role to play in outreach and information dissemination. I mentioned therapy by walking around in the Pentagon context. It could be done in almost any context. Using established community structures, that's usually churches or other gathering places, using the politicians, whatever, and a combination of flyers and websites. And the flyers are useful because many times, again, people won't go to website and power down. Ma'am, in the back? I'm not going to let Lindsay sit down. And I asked her to take notes when you guys had good things, so I'm multitasking her. So, Carla, you're going to have to be up and ready, too.
I'm Phyllis Freeman. I'm professor of psychology here at the college. I often see suggestions of outreach using websites, knowing full well that when the wind blows in our local community, not only does the power go off, our water goes off, and certainly websites go off. But what also surprised me in the last day and a half is I haven't really heard anybody talking about using social network sites and using Twitter and Facebook and other forms of electronic communication. I think given what I see my students using, even while I'm teaching,
especially while you're teaching.
Especially while I'm teaching, that's a source of information that I often don't see discussed. And I hope as in part of the planning, we'll think about using those sources.
That's a very good point. You know, of course, these guidelines, which we're updating now, it was prior to Twitter and Facebook. So I think that's a very good point. And I think somebody mentioned it yesterday. Do we have another comment here? Okay, so let's move on. Again, our job is to provide technical assistance, consultation, and training. Ray Suarez yesterday, when I asked a question about how we're partnering with the media, and he made a point that was a good one, that we should already know who our media outlets are in our local community. And many of us, and certainly myself, are conditioned you don't talk to the media without going through public affairs. And I actually have done a lot of media work, but there's good sides and bad sides. So I think we've got a discomfort there. But we probably have to break out of our discomfort and, of course, make the relationships prior to the disaster with all of these stuff. Because people, when you come up to the mayor and he's just met you after the water tower has fallen down, he's not going to have much time for you. Fostering resilience. 10 years ago, this was kind of a new concept. Now everybody talks about it. I've gotten so tired of the word resiliency. It's a buzzword. We all want to do it. The question is how to do it. And I think there are some ways that aren't often explored. And a lot of it has to do with repairing the organizational fabric. After the Pentagon, as I mentioned yesterday, people were working really, really long hours. Well, one of the best interventions I did was come into a workplace and said, when did you last go out to TGIF? Thank God it's Fridays. And of course, they hadn't gone out for, this was 6-8 weeks after it. Well, go out as a workplace, have a chance to talk to each other. Foster the normal reactions that are there and repair what's broken. Now, you also see that the bottom bullet here is operational debriefings. I mentioned at the beginning, I haven't gone completely against debriefings. I think they can be very useful, especially when they are a standard response in a first responder community, fire, police, etc. And usually done in a fairly short period of time and in a cognitive way rather than tell me what you thought, felt, etc., etc. How many people are still using debriefings? We got a kind of a couple timid hands. You call them hot washes, okay. So a short, quick thing. What about you?
Yeah, I
Okay. And so how are you doing the debriefings now? And you've got Lindsay with a mic right.
We've always done them, and that is, I don't really need it, but okay. The same way we've always done it, and that is the populations are first responders, primarily volunteer fire companies, some EMS, and oftentimes with police. They always are preceded by full assessment to determine, who's most affected. We don't want to put the whole group together because having everybody together might not be a very good idea, because there may be one individual that's highly aroused and really would benefit more from an individual one-on-one than anything that's going on with the group. And it's always offered in addition to a full array of other CISM services. In addition to the one-on-one, we're really heavy on the pre-incident education, diffusings. We rarely do demobes. But you know what I'm saying? It's not a one-size-fit-all. It's not that we just go in and we're a debriefing machine, in and out, end of story. It's always preceded by a lot of other stuff. And then when we do it, there's always a lot of follow-up that occurs.
And that sounds like a very good model. Okay, triage. So our job as mental health professionals will be to do some triage. Again, it's not all a population of people who were psychologically healthy before, who have had a single event, who just need these sort of normal reactions to abnormal situations. There certainly is that, but there are going to be some people who are really suffering, either because they're off their psychiatric medications or many losses or overwhelming grief. So you do want to keep your traditional things in mind as a backup. And then treatment. All of this you know how to do, so I won't belabor the point, other than to say that when I was in Iraq the first time, I saw a lot of people who were in the streets off their psychiatric medications who were being used. This actually didn't happen later, but they were being used as suicide bombers, because you're vulnerable, you're chronically mentally ill, are very susceptible, and so can be used actually as agents of war as well. For chemical and biological response, what we see is a successful medical response really decreases anxiety. Remember when anthrax first hit and there was discussions about a 95 or a 99% fatality rate? People were pretty scared. Nobody knew where it was, and people were dying. And then we were recognizing it, and we were treating it with antibiotics. And nobody's ever really talked about this or written about it, but I think the country kind of went through a collective, I can just take some doxycycline, no problem. And we sort of moved on. So effective management of casualties, and of course good risk communication, which is throughout all of this is important, but especially in sea burning, and again chemical, biological, radiological, and what have we just seen in Japan is fairly much a failure of any kind of risk communication with consequent fears. Okay, I'm going to shift into lessons learned. Do you guys want to take a break now for 15 minutes and then come back? Raise your hand if you want to take a break. Raise your hand if you don't want to take a break. Okay, we're keeping going. Anybody who needs a break can slip out. I talked a little bit about the Pentagon yesterday. I'm going to come back to that. These are going to be some of the best practices I'm going to touch on. I'm going to spend a fair amount of time on Fort Hood because I was pretty involved in that. And, of course, the Pentagon. Others, I'll allude to what I know, but this is where I really want you all to jump in. And since I've got Lindsay as a note taker and Carla helping with the mic, we're going to have both of those going on. So we discussed this yesterday. What I didn't know yesterday was that the National Transportation Safety Board apparently had a great meeting, from what I hear, last week, where they covered a lot of issues around family assistance centers. And Valerie, was it you that said you were there? Do you want to say a word or two about the meeting?
That's great. Tara Hughes, I'm with the Red Cross in New York State. I'm the DMH state advisor. And I was at the meeting for the NTSB last week where we were talking about really from an international perspective how to take their model and move it into different countries in terms of family assistance and what they are able to do with families. It's a very prescribed event when it happens, when a plane crashes at this point. That's the one that's been most often used. Plane crashes, and there are very particular things that the NTSB has to do. There are things that the Red Cross has to do. And we are charged with the care of families, survivors, and the emotional side of the injured, not the health side, that they're usually in hospitals. So this meeting was great because it really talked about everything from how do you actually run a family assistance center from the NTSB's perspective, but it also gave a whole lot of information about why it's important for people to do this. And the families who were there were both from pre-1996 when the Aviation Act went into effect and post-Aviation Act. And the one thing that everyone agreed on was you have to get it right the first time. So understanding beforehand what you need to do is critical in order to be able to do it and to do it well. So.
Valerie, did you want to add anything, or Tara pretty much covered it? Actually, before you take the microphone away from Tara, we had our little deep blogger therapy last night, and I asked Tara about the Buffalo event, and you talked about what happened with the families, and without revealing any secrets, can you just say, describe how the families gelled when the families said no?
It was a very interesting event. Buffalo's crash was interesting and unique in that most of the families were from the Buffalo area, the majority of families. Not that they knew each other prior to that, but when we were all in the Family Assistance Center, we had moved from what's called the Friends and Family Reception Center to the Family Assistance Center, and that was indeed a hotel that had rooms, and many people were actually staying in the hotel 24 hours a day. And that's where the NTSB was having briefings. The hotel was actually not ideal for a family assistance center. The room that we were in was fairly small for the briefings, and there were not many places for families to gather outside of their actual rooms. So the airline decided that they were going to move everyone to a different hotel. And they came into a briefing and said that, and in unison, and it was actually kind of comical when it happened, in unison, everyone sitting in the room just said no. There was no real emotion behind it. It was just, no, we're not going to go. And at that moment, they really gelled as a group. That was the morning briefing on that day. At the evening briefing, they actually asked everyone who was in an official capacity to leave the room so that they could have a family meeting. And they are still continuing to meet now. And they've done a lot of advocacy for airline safety and those kinds of things. But that moment when they were told that they had to move and they just all said no was the moment that they really came together as a group, which was very unique, very interesting.
Steve, Lindsay.
Hi, I'm Steve Moskowitz with New York State Office of Mental Health. And I just wanted to make a mention that sometimes it's easy to confuse terminology because we use the same words all the time. Family assistance centers are defined by federal law as being under the auspices of the airline and the Red Cross for response to aviation disasters. That's by a federal law. That does not necessarily extend to a non-aviation disaster. So it could be a circumstance where a family assistance center is set up outside of that definition, and one shouldn't assume that because of their familiarity with the way that it works relative to airline disasters or transportation disasters, that that's the model that is always used.
Is there another name than Family Assistance Center that's preferred? No.
No. If it's dealing with the families in a mass casualty situation, then it's going to be a family assistance center. The other types of centers you see at disaster sites are generally referred to as disaster resource assistance centers, and that's usually a FEMA operation.
There's a hand in the back of the room. Carla's got you.
Hi, Tom McCartney from New York State Office of Emergency Management. In the Broome County area, we dealt with the ACA shooting incident where we had 13 victims at the ACA facility and then one shooter, a family assistance center was set up to support the people coming in, and the lead agency supporting that was New York State Crime Victims, supported by the Red Cross. So it had a different twist. The State Crime Victims had great support out of the State Bar Association, various agencies within the Disaster Preparedness Commission in New York State provided support to that. But Red Cross came in and supported it and did a great job in a support role, but Red Cross was not a lead in that. But again, this was not an air disaster or anything like that. It was a criminal activity, and it was outside the scope of Red Cross purview.
Okay, again, I talked briefly about Operation Solace yesterday, but I wanted to come back to it as an example of a best practice. And at least for us in the military, we use the principles of combat stress control, the getting out among the troops, and it worked really well, and it had a very positive long-term outcome. Okay, now the tsunami. Anybody involved with the 1994 tsunami? Okay, my involvement was relatively limited. We had formed relationships, as we always do, and at the time of the tsunami, those relationships were activated. Project Hope is a non-governmental organization. I think most of you know it, it's sort of the big white ship. Well, actually, what they did this time was they put everybody, a lot of medical providers, mainly from Mass General, but from all over the place, onto the Comfort, which is a hospital ship in Baltimore. We did some just-in-time training there. Then the crew was flown to Singapore. The Mercy left San Diego, and they joined in together and ended up at Bande Aceh. We provided some just-in-time training, and we actually did some surveys and were able to measure at least the self-report of people to our just-in-time training. One of the things that was very clear from this was that all the complexities that you know of in terms of command and control that you have in the States were just totally multiplied by being in this setting. Numerous non-governmental organizations, numerous, the UN, UNICEF, et cetera, et cetera. And it was a major effort which actually, I think, worked quite well. One of the things that we talked about when we were doing the training was exactly this. And again, this was just-in-time training for medical staff, some of which had been to disasters before and some of which weren't. So we talked about the evolving and unclear chain of command. We talked a lot about the dealing with dead bodies. At the time we did this, we had been seeing pictures of the bodies stacked like driftwood on the beach. Actually, by the time the ship got over there, that was pretty much resolved because it was about 6 weeks later. And more of what the group did was provide medical care to a population that had a stored-up need for medical care. What they expected was kind of to be overwhelmed by horrific sights. Actually, what most of them found, what most of us would find, is that they felt frustrated at being stuck on the ship. There were a lot of security issues about going ashore, and there were concerns because of that big red cross on the side that the ship was a target. And so many people who wanted to go ashore and help couldn't. And if they were in surgery back on the ship, there was plenty for them to do. But other areas, there wasn't very much for them to do. They also expected to be able to call home, talk home. You know, this was 1995. 1994, so that people were used to the internet and they couldn't, and they found that very frustrating. Another issue was integrating the military community and culture with the non-governmental community. This came up over a couple things that trip people up all the time: sex and alcohol. In the military, you're not allowed to drink on a ship, and you're not allowed to have sex. And there were times when the NGOs didn't understand those rules, and people got in trouble over that. However, when we went back and looked at our training, most people thought it was effective. Usually the people who thought our training was effective thought other trainings were effective, and the ones who didn't like any of the training didn't like ours either. And it really underscored the critical importance of morale, cohesion, and communication. Because these providers had come in from all over the place, and because they had several days, really almost weeks together on the ship, we really emphasized cohesion building activities, and they were able to do that. The Project Hope has continued to work with the Navy and has continued to staff the hospital ships, the Mercy and the Comfort. They've got a rich data bank right now, and it's something that's really worked well. So again, some found the training helpful, some didn't. Some staff were underutilized, some overworked. And a theme that I think I've said before and that you all know is although we managed to get a little survey data, it's hard to do good research in a disaster. Katrina. Do we still have the psychologist here? Okay, we talked to him and his wife last night, and I've talked to a lot of other people about Katrina, was not directly there. Who was there in Katrina? Okay, Valerie and a couple of people on the side that I haven't met yet, so be prepared for your own experiences. So there were a lot of problems with the Katrina response that I saw from a distance. We were sending in waves of counselors. We was actually SAMHSA at that point. I was working as part of the American Psychiatric Association Disaster Psychiatry Committee, so we were sort of putting out calls for volunteers, etc. But, of course, people had moved away from New Orleans, and so when they got down, in many cases, who were the patients to treat? I've got a good friend who's a psychiatrist down there, and he was very frustrated because his patients were leaving, and there were other people coming in providing care for free, and he's a good-hearted soul, but he also needed to make a living, so what was this doing to his own income? Again, everybody was going to New Orleans. Other places were underserved. The importance of pets. People who had to leave their dogs and cats behind, they thought they'd be gone for 2 days. They were gone for weeks. They were gone for months. A lot of rescue efforts for animals. A lot of animals brought up to other places, and a lot of animals that died. I got my dog shortly after that. I got a pair of little Shelties deliberately that they were small enough to fit in the car if I had to go someplace. Are either of you over here able to share some thoughts or lessons learned from Katrina? You had mentioned you were in Katrina. Do you have lessons learned for us from there?
I went as a firefighter.
Okay. And you've got a mic coming right to you.
My name is Jim Van Houten. I'm a firefighter and a fire chaplain, and we had the opportunity of going to assist in any way we possibly could. Counseling was one of the things that we did. Most of the time we would find people who were in need of mental health and would direct them to the services that were available. Really wasn't much else we could do. I think everyone who responded found themselves to be very, very limited in whatever area we were located in because of transportation. But most of the time it was just meeting with the people, talking with them, trying to understand their problems, and then directing them to further help.
One of the big issues for many of the counselors that I was told about, again, I wasn't there, was that the shelters became very dangerous places. People who were in the shelters often were addicted. One of the things you find with a disaster is that people who have the socioeconomic resources to get out of there do so, and so you've often got the socially disadvantaged, and heard a lot of stories about people, volunteers being robbed, being threatened. I don't know how much of this is true versus apocryphal, being threatened with a knife. And I think that we, and I'll just use a collective we, didn't do a good enough job preparing people for what they were going to walk into.
In the time we spent there, we never encountered anything like that. We weren't threatened in any way. People were delighted to see us. As I said, we were so limited because you talk with someone, you realize their need, but we couldn't get them to any other shelter. We were kind of stuck in that one area. So we could only direct them to the mental health available in that small location, and then we just had to wait until transportation was available to move them to another location. But no way were we ever threatened or felt in danger in any way.
Okay, well, there's always apocryphal stories, and that's one of the challenges. Sir, behind, do you have anything you can share with us in terms of lessons learned from Katrina?
Sure. I was assigned by the federal government as the deputy administrative officer of one of the National Disaster Medical System teams, the DMATs.
Tell us your name.
My name is George Liu. I currently work for the Office of Health Emergency Preparedness in the New York State Department of Health. I think you've pretty much touched base on a lot of things that I encountered in my experience down there. There were isolated incidents of violence on the responders. My particular unit was not subjected to any violence, but I think during the first week, people who went down there were kind of, I guess, put up against the wall. And again, it goes back to hoarding and looting and the possibility that if you see someone with a particular item you don't have access to, if you don't have access to it, you want to get to it. And I think one of the things that we did learn from seeing the first week of, anxiety, we realized that to mitigate fears and possible mental health outcomes, we needed to also address somatic issues. For example, people had a fear of Hep A, they had fear of tetanus, and even though the CDC issued a mandate not to vaccinate people rampantly, just randomly vaccinate people for Hep A and tetanus because it really wasn't needed, there was very little of it going on, the NDMS system decided to go ahead and take stockpiles from the SNS and vaccinate people who wanted to come to the shelters or the medical aid stations for vaccination. There was quite a few people who took that up, I think, on a daily basis. I was also the epidemiologist on this team, so I had access to the medical records and the numbers. On a daily basis for the first 5 or 7 days, anywhere from 1,000 to 1,200 people came for vaccinations.
Wow.
Which is quite, but again, this goes back to psychological first aid. If people feel that they don't have fear of a somatic issue, they're less likely to be anxious and they're more likely to address other issues and take care of themselves.
Okay.
Oh,
I'm sorry. Up here.
my name is Abby Mack, a social worker and a Red Cross volunteer, mental health for 16 years. I was in Gulfport. We were in an elementary school that was very dangerous where we were located. The toilets had already overflowed where these people were. There were cardboard on the floor where people were walking in feces. You were right, the area was very poor to begin with. The first several blocks of Gulfport had been sucked back out into the Gulf, so there were dead bodies and all kinds of refuse there. Animals were brought to the shelter where we had set up. Luckily, the Air Force Base was there, and they brought a medical team because we had people who were injured that hadn't been gotten to yet. We didn't have latrines for several days. You talk about Maslow's hierarchy of needs, the issue of food, clothing, and shelter, and safe food, clothing, and shelter were a big issue. It took a while. I mean, as a Red Cross volunteer, I'm sort of used to this, but it took a while for really important things to happen. It was at least a week before people that were staying in our shelter, I think, felt safe along with the other volunteers. So it was unsafe there.
Thank you. Long-term issues. I went back to New Orleans the week after Christmas, and that was just a marvelous experience for me, very powerful. I don't know whether you all have gone back, but one of the things that, and you've heard this, so the Garden District and the French Quarter have recovered. Other places are still very devastated. But there's just fleur-de-lis everywhere, and there's such a sense of pride. It's really, really exciting. This to remind you of the importance of pets. I said I was going to call on you for a little experience. We are using a lot of animals with our wounded service members. That, and as I mentioned, that's both with physical wounds and with people with post-traumatic stress disorder. That has not gotten yet into evidence-based practice, so I'm not going to present it to you yet. But 5 years from now, yeah, why don't you hand her the mic? Tell me what you're doing.
Hi, my name is Diane Anderson, and I'm with an organization, well, it's not my full-time job, but I am with a non-for-profit organization. It's called Animal Assisted Crisis Response. And what we do is we train people and their dogs that are already doing the typical therapy dog work that we know of in hospitals and nursing homes and that. And we're giving them a more advanced training in regards to being able to work with their dogs in disaster situations. So at Katrina, we had dog teams down at both in Louisiana and in Texas at the stadium there. We do a lot of the school shootings. We've been at NIU, Virginia Tech. And basically, our tagline is we break barriers and build bridges. And the training that these folks are getting is really not only how to intervene with individuals that are, and first responders as well, that have been exposed to disaster, crisis, or trauma, but really help them move towards the mental health counselors that then will take them the next step. And these folks are trained, again, not only to do those interventions, but they're also trained on the incident command structure. They're all required to do certain FEMA courses so that they understand how to interface with these bigger organizations that we partner with at the different disaster sites. And we've done presentations. Jan Schubert from the EPA has been very involved in getting us more exposure and more work with on a more national level. Does that answer your question?
It does, and there's a hand in the back. I think the group's probably almost ready for a break, and we'll take the question or comment in the back, and then why don't we do a 10-minute break, and then I'll come back, and as I said, I'm going to spend a little time on Fort Hood because I was pretty involved in that piece of it.
Brenda Pittman, Pennsylvania Behavioral Health Response Consortium. We actually used ACR crisis response dogs in some very large public vaccination clinics, and when the dogs came in, the sound level in these large rooms just totally went down because we had kids who were very anxious about getting their shots and stuff, and it just changed the whole scenario. So the impact that they can provide is great.
And I think your question is a very good one. Well, Carla's coming down with the mic, just to sort of paraphrase it, you were asking about the what MR/DD population, mentally retarded, developmentally disabled, which I had not separately broken out as a special vulnerable population. And I wanted you to say a word or two about what the needs of that population were. And then if there's anybody else from the group who can help join the discussion.
My name is Linda Serto. I work for Occupations, which is a large agency in Orange County. I'm also part of the Red Cross. And I'm not finding any literature out there for that particular population, for the MRDD population. Many of them live at home with elderly parents, or they live in group homes. And my agency is very focused on what to do in case of a large disaster, how to best assist this population. And we feel like we're reinventing the wheel, that we're not finding information as to how specifically to help this population.
And can you describe a little bit more? My interpretation of what those special needs are would be increased confusion about moving around, perhaps some inability to adjust to new places. Can you say a little bit more about what you've seen?
They're not always very good historians, so they might have difficulty presenting information requested of them should they need to transition off into new environments or to new caregivers or new assistant places. Sometimes there can be behaviors associated with their diagnosis that may be very confusing and unfamiliar to people who are trying to help. They may not be able to easily identify when they have a medical need. Their behaviors might increase if there's a physical distress. They could have concomitant medical issues as well that they're not able to tell people about. It's very complex.
Well, I will certainly put that into my next slide set because I think that's a good point. It's not a population that I work that well with. Ma'am.
Hi, I'm Patricia Finley. I'm a social worker with Rutgers University, and disability is an area of of interest for me clinically. And working with people with disabilities, we recommend that they create like a toolkit for themselves where they keep lists of their medical equipment, their medications, keep it updated. Years ago, there was a program called Vial of Life where you kept important documents like that in a plastic container in your refrigerator. So if something happened, you'd go right to the refrigerator, be able to pull it out, and it would document that. But you need to update that. We always recommend people with disabilities keep at least a week's supply of medication, if possible, aside, along with any instructions on how to use their personal assistive devices, because you're right, they can't communicate that in case of emergency, especially if they become, anxiety overtakes them, or there isn't a caregiver there to help. But it's not prevalent in literature. It certainly is an area that needs to be looked into.
So sorry. That might work for mild MR, but for moderate or other levels, it becomes a real issue. And I'm concerned if there is a big disaster up in our area and our staff is unable to come in themselves. We're working on trying to address this, that it's going to be a big issue.
And obviously it takes a lot of preparation and planning. We've got Lindsay's coming to you in the back.
I'm Judy Watt from Office of Mental Health in Monroe County and the Disaster Mental Health Coordinator there. I also work on special needs, and ROMH oversees the DDSO population as well as OASIS people and mental health. But as part of my special needs role, we've done what we call a phase 1, phase 2 around special needs. And any of the nursing homes, group homes, whether it's mental health, OASIS, or DDSO, we've reached out and we've divided our community into sectors. And so that these group homes have all been contacted, which again includes the developmental people, so that if we had a bioterrorism event, had to get people for medication, we would push medications out to these people because we've made arrangements where representatives of the group homes would come in and get it. And then for most of the agencies, they do reach any of their outpatients or schools, would do outreach to the parents and families so that they would have some plans set up. So that's our phase 1 with the more organized group homes and agencies. And then our phase 2 is really pulling people who live within the communities together to say, where are your populations of people and who knows about them? So if we had a crisis, we would have a contact name, say for a church community or senior citizen center, or if there's a day program for developmental people, where we could just call that one person and say, find your people. Who are they right now that are going to need extra assistance? So we've been working on that. We've got quite a bit done on the phase 1 for the more organized group homes and organizations. And now phase 2, it's engaging people within the communities who would know this, because many people get along on a day-to-day basis, but then if there's a crisis, they may not get the information or not be able to really move beyond their homes or a small circle within their neighborhoods.
We've had some discussion about writing up this conference in one form or another. I would perhaps make the suggestion that a chapter or a piece in that tackles exactly that subject could be a very good assistance in the literature. And I bet the three of you would be great authors for that chapter. Okay, let me switch into the Fort Hood reaction. And Fort Hood was something that was very near for me and very painful because obviously the shooter was another Army psychiatrist. And so I had the interesting sort of being in the tragedy and help planning for the tragedy and trying to react to it and keeping my head together and being over at the Pentagon all at the same time. I think the model that came out of it was a good one, and I'd like to share that with you. In the Army, we call things a concept of operation, and so I'm going to show you some of the official briefing slides. And again, a slightly different model. In Army official briefing slides, you've always got an agenda in the beginning. I'm not going to go through this whole talk, but just so that you could see what it is. And you always have a purpose and a mission. And I think some of this is, boilerplate language, but is fairly useful. We had subject matter experts from the disaster field, both inside the Army and outside, come down, and we had a day-long symposium, which was partly to do a course, either correction or validation of what folks were already doing. This is also a useful concept. I think it first came up around the time of the Gander crash, the idea of concentric circles that are affected. And this is not news, I know, to any of you, but again, is a useful slide and a way of conceptualizing to the outside world. So those in the middle is obviously the most immediately affected, but then you think about a variety of other people, and in this case, children in schools, a larger Fort Hood community. One that is a little bit different is the patients of Major Hassan's and how they would be affected, the larger military community, Colleen, and of course the nation. So the idea was to start and execute a long-term behavioral health recovery plan, because everybody recognized that there was going to be short-term response and then an immediate, intermediate, and long-term response. Set up a behavioral health coordination cell, which established coordination, developed priorities of care, identified additional assets needed, immediate, short, and long-term care, consultation, environmental monitoring, a public message which communicates the strategic plan, and a continuous assessment of the deployment of units that had been affected. We have in the Army something that used to be called CHIPM, Center for Health Promotion and Disease Prevention. It's now called Public Health Command, and they have a mission of doing monitoring, and they were sent down to do a lot of surveys. I mentioned that at the Pentagon there were kind of attempts to do surveys. Here it was much more systematic. One of the challenges was many of the people who were present at the time of the shooting were deployed fairly quickly after that to Afghanistan and Iraq. So that made the challenges of doing surveillance, and they're just beginning to start to come home now, because of course we're about a year and a half after the shooting. So this was the immediate phase, sustain and continuity of care, identifying all the assets that are available. And in this case, I won't go through all the acronyms, but we had providers from Brooke, that's BAMC, Combat Stress Control Teams, Defense Center of Excellence Team, Uniformed Services University, MFLIX, our Marriage and Family Licensed Counselor, MedCom as chaplains, RMC's regional medical centers, so we drew from the other regional medical centers, the Air Force, the Public Health Service, the VA, TRICARE, and non-governmental organizations. Ma'am. That is personnel. So the question, what is PACS, is personnel. BH is behavioral health. The Army thinks that mental health is too stigmatizing a word. They use behavioral health. The DoD thinks they should use psychological health. We sort of go round and round on that one. So this is saying who are your immediate assets, who are your midterm, and who are your long-term assets. And again, breaking it down by immediate, short-term, and long-term. Don't want to read the slides to you, and you all have this on the handout, but I think you can see and recognize what all of these are. The Army puts things in terms of campaign plan. So the idea was a Fort Hood campaign plan and how you would execute it. Oops. And this was executed, I think, quite well. What didn't work as well as we wanted it to was the surveillance. A lot were lost to follow-up, and a lot of people who just didn't want to participate in the survey. But by and large, we have had very few negative consequences. Also, to remind you, one of the things that made this especially difficult was that Major Hassan shot up the Combat Stress Control Unit that he was scheduled to deploy with, so we lost mental health personnel, people that we all knew. again, I had been used to sort of being in the first responder role of a disaster. This was different for me as being both affected and helping to plan the recovery. But that's also what many of you will have as if the disaster follows in your community. Any questions or thoughts about Fort Hood? Sir.
There's no way any system could predict any kind of behavior like that.
The question was, there's no way to predict any kind of behavior like that. What I found is when there's a suicide or a homicide or a bad event, and you go back and you retrospectively look, there's often a lot of red flags that when you look at it afterwards, you say, oh, well, somebody should have picked it up. But also I find that when you look at it, and I'm broadening your question beyond this particular case, because of course the investigation is still ongoing. So if you go back in retrospect, you can say, oh, the captain knew this and the chaplain knew this and somebody should have known. But very often the pieces are not all put together. One of the responses the Army has had is they've said, well, we do a lot of screening for suicide. Why don't we start screening for homicidal behavior? So there's been more questions implemented on our post-deployment assessment and reassessment about violent behavior. In my experience, people who are going to commit violent behavior usually don't report it on a survey before they do it. So I'm not sure how useful that will be. In the world, in my world, also as in many of your worlds, there's often a blend of politics and science, and you have to try to, and then policy that comes out of it, and you have to have the policy that follows the science, but the politics is always in there as well. Did that answer your question?
Not really, but that's okay.
Okay. All right. So Haiti, more recent experience. Unfortunately, I think that the response to Haiti, which I was not part of but have been sort of seen other people go, had a lot of the problems that the tsunami had in terms of the fog of relief, multiple agencies going to it, and a very, very impoverished country. And I think we all know that a year plus later, the city is, the country and the capital is still in a very difficult place. Did anybody respond to Haiti? Does anybody have lessons learned from that experience? Tara? You didn't respond, but you've got lessons learned?
I did respond.
Okay.
But what I did was actually, I was here in the States working with the State Department, connecting families with their remains as they came back. And one of the things that, even in that small experience, was that they were dealing with the military, the State Department, and the Red Cross, and even just 3 organizations were sometimes incredibly overwhelming to the people as we talked to them. And we were trying to mitigate that as much as possible. We were really conscious of who needed to contact them and when and all of that kind of stuff. But even then, it was still just 3 organizations. And in many of these responses, you get that tenfold. People that they have contact with. So it's just something to remember that I think I will always remember now, how overwhelming it is to have a number of different agencies talking to you at the same time.
I asked a colleague of mine who was involved what his lessons learned, and he said 3 things, and one of them, the acronym I didn't understand, so I'll skip it. But the one and the third were, first of all, respect the local government. And third was that the non-governmental organizations really need to make sure that the folks who go down there are trained and have some kind of credentialing process. So that's a familiar theme to all of us. I think it's heightened further when you're going into an impoverished third world country where a different language is spoken and there's a different culture and there's a lot of danger still around. Okay, so the Gulf oil spill. The big take-home message for me, and there's many messages here, and again I'm going to ask, did anybody work the Gulf oil spill? Okay, so is that was a prolonged, environmentally very dirty situation with a very heterogeneous population. So we worked with NIOSH and OSHA, the National Institute of Occupational Safety and Health, to look around issues about how do you monitor the health of first responders or the people who have been living there. And I think that was a really good effort, but the challenge becomes you can screen all you like, but how do you make sure that the data gets to a centralized place where you can monitor it, that the data goes in some place, and that the people get care. So you can have the idea of having a big registry, but what do you actually do with that information? Now, I've mentioned the post-employment health assessment and the post-employment health reassessment. Those are the screens that people fill out after they return from Iraq and Afghanistan, and that has actually, despite my initial doubt, turned into a very useful tool as a snapshot as somebody's feeling. However, it's not particularly clinically useful. I find whenever there's a suicide, people say, well, what did they put on the PDHA or the PDHRA? And you go back and look at it, and of course, there's nothing on the PDHA and PDHRA. Because people were doing just fine. But I think that as a community, we need to be moving further towards a better monitoring of our health, of the health care of our first responders. Anybody want to add to that? Got Valerie here? And of course, we had the epidemiologist over at Katrina. I don't know if you have any thoughts about that as well. Okay.
I just happen to be close to the microphone, so. But in the Red Cross, as part of our post-deployment support, we have a post-deployment stress questionnaire that we're starting to give people. We don't have any data really collected yet, but we are starting to look at stress outcomes for people when they return from assignments.
Why are you just looking at stress and not exposures to various toxins?
I don't know. I haven't thought about that.
Okay. Our post-deployment health assessment grew out of the first Gulf War, when there was a concern about Gulf War syndrome, the concern about exposure to nerve gas and sarin and sand and petroleum, and we hadn't done a good way of capturing exposures, so we fielded the post-deployment health assessment in 1998, and it was pretty much a focus on exposures. We added questions about mental health, and then we added, first we had the one that you did as you came back from theater, but realizing people weren't going to tell the truth, we added one 3 to 6 months later. I think it's a much more powerful tool if you also ask about environmental toxins. We've added questions also about traumatic brain injury to it. So consider that. And by the way, the forms I just mentioned are on the website. Just Google post-deployment health assessment or reassessment and come right up. And we are able to capture all that data into a data bank as well. Did you change your mind?
No, I'll
Okay. But then you're going to leave the rest of the group out who wants to hear. Ma'am. Hang on just 1 second. Again, we've got they won't be able to hear you on the webcam without the mic. Okay, there we go.
I work for a different organization now, but I used to work for a center of excellence. I used to work for 2 centers of excellence, actually. With first responders for 9/11, and through that worked with the registry with the Department of Health. And
I'm sorry, just to clarify, so that was a 9/11 registry you're talking about? Okay.
Well, the Department of Health has a 9/11 registry, 70,000, but which is combined of community residents and first responders, which is self-report. And so they have that data, and then they have the data through the Centers of Excellence themselves, which they have monitoring once a year, plus the data of the people who are patients in each center. And I'm wondering, at BP, have they set up any health centers for the people exposed to the toxins at these sites?
What I understand, and I have partial knowledge, is that BP is going to be monitoring the health of its own workers. But there's an immense amount of contractors and first responders and shrimpers and other folks that don't fall under BP's purview. So it makes it a very complicated situation as to who would be responsible for monitoring. In terms of lessons learned and how do you incorporate that into disaster planning, I think we as a society need to have things, that we can pull off the shelf that are going to say, this is what we're going to use, and we're going to do pre-deployment, post-deployment, whatever, and so that somebody starts to use it, and then you kind of sort out some of the other issues eventually, but we're not there yet.
Yeah, well, I mean, NIOSH, in terms of occupational disease, I think should be part of the discussion.
Well, they are. They were the one that convened the meetings. No, it was NIOSH and OSHA, and they're definitely very interested. Coast Guard was there because they were doing a lot of the deployment, and of course, Coast Guard, like the rest of the military, has very good records on their providers and people who went in and out. Okay, let me come up to today. I can't tell you that many lessons learned. I don't know what they are yet. We do know that Japan was an extremely well-prepared country. We also know that it has a legacy of the atomic bomb, so the radiation threat is pretty, I think, a very, very psychologically toxic threat for them. There was an interesting NPR piece the other day on the aging elderly population. Did you all hear it? So populations that had been displaced that really were in their 80s, and the idea of setting up anew was very hard, and it sounded like there was still some denial about that their city was gone. The lousy risk communication. I had a thought myself that I didn't know if anybody else had, which is we've been through so many disasters that personally this one I just sort of like another tsunami, another crisis. I couldn't get excited about it. Then I got asked to go over to Japan, and I started to get more excited, and I think when you're personally interested and invested. But for right now, it sort of seems remote and playing out there. What are other people's thoughts? Has anybody been directly involved in the Japan or indirectly, or who has any lessons learned? What about our UN colleagues? Raise your hand. We've got a couple folks from the UN here, if people haven't met them. Have you been at all involved over in Japan?
No, we haven't been. We have about 200 staff members who are all in Tokyo, and we're not very affected there. But I had one observation, that the news coverage focused, Japan was hit by 3 disasters, an earthquake, the tsunami, and then the nuclear disaster. And unfortunately, the news coverage focused mostly on the nuclear disaster, and we lost touch with the human feeling and the human suffering that followed the tsunami and the tsunami. So that part, there's a sort of vacuum there of feeling for the people and actually what they're going through. That's just my comment.
And part of the focus, I think, on radiation has been how will that affect us? Will the price of sushi go up? Will it contaminate the air, water, and soil in Hawaii? And so my comments before about the sort of ubiquitous fear of these agents that we can't see. Now, of course, we can measure radiation, but we're not measuring radiation here, and I think that's part of the reason. There was also a very interesting discussion. NPR, I think, has been great about both the coverage in Libya and the Japan. They had their piece on Godzilla and how the films have helped folks manage the fear and anxiety about the Japanese meltdown. Okay, well, just to sum up again and to take any more comments, as I said at the beginning, I think we really need to move the lessons learned into the planning. Dan Dodgen, some of you know, he's now over at ASPR, which is the Assistant Secretary for Preparedness, Health Planning, and they're doing a large concept of operations, and I think that's one way they're doing this. We have applied for a SAMHSA or grant to try to put out kind of an update of where we were 10 years ago, And I also think, again, this venue might be a very good opportunity to try to get out any more lessons learned. So I've covered time phase planning, psychiatric medications, family assistance center, risk communication, international command and control, environmental monitoring, and ongoing health assessment. Now again, I'd like to turn it back to you before we close. Any other questions, discussions, lessons learned? Valerie's looking embarrassed.
I know. I hate people who dominate the conversation, and here I am speaking again.
But you've got good things to say.
Okay.
I sit next to Carla, or Carla sits next to you.
Anyway, I just wanted to say something to Linda's observations about the DDMR population. I don't know how many people are aware of the FEMA directive about shelters that FEMA and Red Cross signed an MOA around functional and access needs planning for shelters. And basically what this is saying is that unless somebody has acute life-saving medical needs or is a danger to themselves or others, that they should be accommodated in shelters, any type of shelters. And so the Red Cross, in terms of their planning, are really working now to make sure that we are able to accommodate people of all sorts of disabilities coming into shelters, including people with MRDD issues or psychiatric issues, and so that those are part of our planning for shelter accommodations. So just to, I don't know if that helps or not, but...
Valerie, let me ask you a question. Should all shelters be able to take all types of persons with all types of disabilities, or is it better to have certain shelters that are basically set up for people with special needs?
No, general population shelters, in order to comply with FEMA guidelines, are going to be taking everybody.
Okay.
Just a comment to that. My name's Eleanor Troy, and I'm from the Ulster County Health Department Preparedness Program. And that is just so non what the Red Cross was about previously, correct? No?
Actually, it is what the Red Cross was about previously, only not all chapters knew it as well as they are learning it now. But we've always been open to everybody. One of the things that we learned in terms of what happened during Katrina was that there were so many shelters set up during Katrina. We had 1,200 shelters open during Katrina. The most we had open at one time previous to Katrina was 400. So during Katrina, if you showed up and you were literate and could walk, talk, and chew gum at the same time, you might have become a shelter manager. And because there was just such a need at that time. And so during Katrina, there were people who were refused entrance into shelters or who were asked to leave shelters because of psychiatric issues, but they should not have been. And the problem was that we had, people who were not very well trained because they were, we had 1,200 shelters open for a long time. So.
Well, it's just interesting to me because that is not the message we have heard here in New York.
And what is the message that you've heard here in New York?
Special needs shelter was not the responsibility of the Red Cross, and that they looked out to the local health departments to be able to substantiate that special needs population.
Well, and the definition of special needs is where that disconnect is. Yeah.
And I mean special needs meaning somebody with a language barrier, somebody with asthma, some simple things that maybe you are able to, live independently, no
Exactly.
problem. But, yeah.
No, you're absolutely right. I mean, the issue of what is a special needs is what has changed. And so there have always been special needs shelters, but now, given certain things that have gone on in terms of, issues around people with disabilities. Now the definition of what is special, well, they don't use the term special needs anymore. So just throw that out altogether. Now we're looking at functional and access needs, and so if people are living independently in their own homes, whether with assistance or in group homes or things like that, then they should be allowed to be in shelters and have the supports that they need to be in a shelter.
We've got a
Can I just say
Tara
one thing to
and
that?
Linda. Go ahead, Tara.
That up until about 18 months ago, there was, in New York State, the plan was written so that there were general population shelters and special needs shelters. That's how the plan was actually written, so that's why you have that term in your head, and that's why everyone is sort of thinking that way. But when FEMA started to come out with this new guidance, that's when everything shifted. So now the current New York State plan is written to reflect the functional needs shelters, but it is a transition for everybody. So.
And they're not separate shelters. Linda?
One of the things that, because again, I volunteer for the Red Cross, I was speaking to my local chapter about this, and they said that they would help us if my agency chose that they would help us to establish our very own shelter within our agency, and that they would provide us with physical supports like heater meals or blankets or cots or even staff to set up our spaces. So, we have had this dialogue. They absolutely said our people are welcome to come to the shelters, but they also wanted to work with what we felt, because we would be the experts on our people, what our people would need, and we felt that that might be one of the things that would help ease a transition in the midst of a crisis. So, but yes, we definitely have been, having dialogues about this, but again, this is really new.
In the back?
This is timely because, again, in Monroe County, this is Judy Watt again, we've started working with Red Cross and have ceased to plan for our special needs shelters that the county was used to planning for, and now trying to integrate resources with Red Cross, again, around their special needs. And again, with the disaster mental health team that I have, we have our joint meeting annually with the Red Cross Disaster Mental Health Team, and that will be one of the topics that we will then let all of our folks know together so they really see themselves as team members. And in any of the events that we've had, the Disaster Mental Health Team, even in the H1N1 clinics, a number of we had over 50 people volunteer, and they were valuable resources. So they're pretty flexible folks, and we expect them to be integrated on call to the Red Cross, because the Red Cross would be our leaders then in these shelters versus the county. So we're beginning to integrate in, and have known it maybe a couple months now. So it's new for us, but it's always been there, is what I understand.
Okay, I'd like to close with a couple thoughts about that reflect the conversation that we had this morning and other times on compassion fatigue or provider fatigue. But I'd like to take a slightly different approach to it, different than the self-care. One of the things that I've been struck by for a while is how helpful it is for people to tell their story. To tell their story in this kind of environment, and I think we heard a very powerful one yesterday with the United Flight 93, to tell the story through Grand Rounds. One of the things that I didn't share with you all earlier, but for both the tsunami and the 9/11 attack on the Pentagon, I gathered accounts of what happened and published it. I put out a book of poetry this last fall, in which was sort of stories about being an Army psychiatrist and tales about being an Army psychiatrist. I wonder if we ought to think about this in a more systematic manner and interject, do studies on, get through the IRB, something about how it heals folks to tell stories and to get recognized for that telling of the story. And I think that that would go a very, very long way, along with the sleep right, get exercise, and don't drink too much, in terms of helping people do this, be in this, stay in this for the long haul. With that, I'm going to ask one more time if there's any questions or thoughts. Up here?
Thank you. My name is Debbie Westfall, and I work for Voices of September 11th, and we are doing a project called the 9/11 Living Memorial, which does, in fact, do that. We meet with families, and we meet actually one-on-one because we found that it has been a mental health exercise to tell the story. So we meet with family members, but we've been down to the Pentagon. We meet with the workers at the Pentagon, and we have found that they have come forward and do find it. When they're done, they tell us, I didn't want to come, but I'm glad I came. And the content that we're collecting is going into the memorial at the World Trade Center site. So.
That sounds wonderful. Now, that sounds like it's oriented towards families and workers.
We have been meeting mostly with families since 2006, and the whole process definitely evolved. We used to do it in a group, but now we meet one-on-one. We set aside 2 hours. We usually meet 4 and 5 times with each family member. But we have been meeting a lot also with rescue, recovery workers, survivors, evacuees, to tell their story. They have, a lot of them have pictures and mementos, and they have given them to us, and they do find it very helpful, I think.
Okay, well, thank you all very much again for your input. I learned a lot at this workshop, which was my goal. I hope that we will see each other again, maybe at a disaster, maybe here next year, and that we continue our work together. Thank you very much.